So I'm going to talk a little bit about severe malaria and outcomes in the United Kingdom, malaria on the ITU in the UK and internationally. And some of this data is mine and some is other people's, some of whom may be in the room. So I'm sure everyone knows this. There are about 1,500 cases of falciparum malaria in the United Kingdom. That's going up slowly, mostly because more people are travelling, even though your risk for each travelling time that you go is going down. Our HPA data suggests about 10% of all the cases in the United Kingdom are severe. You can't actually get that from a malaria report, so that's a kind of extrapolated figure, but that's kind of what people think it is. And just so nationally, 71% of all malaria cases, not severe malaria cases, are seen in black Africans, predominantly returning to visit friends and family. So this is a really wonderful paper, and I would recommend it strongly, by Anna Checkley and Chris Whitty at the school. And they looked at 20 years of UK data for falciparum malaria, and they had about 25,000 people who had been notified nationally, and there were 184 deaths, so that's a sub 1% death rate nationally, so that's not that bad actually. I mean, it's like flu. But in the United Kingdom, as opposed to in an endemic setting, overwhelmingly old age is the #1 risk factor for death, which is the inverse of what we see obviously in endemic settings. So you can see the odds ratio if you were more than 65 was 10.5, and there are no deaths in children in the UK. So being old is a big problem. What else is a big problem? So the other things that made you more likely to die were if you were a tourist as opposed to if you were visiting friends and relatives. So we presume that this is a proxy probably for being a white person going to Africa rather than being someone who grew up in an endemic setting who may have partial immunity. Can't really decide what the word partial immunity means in malaria, but it probably means something. And I'm going to show you a graph of the second one, UK region where disease presented, in a second. You were more likely to die if you presented in December. Don't think we really know why that is, but maybe there were less people at work. Unsurprisingly, not very many people reported effective use of prophylaxis, but it's not a massively powerful risk factor. But importantly, the bottom one, birth in African country with endemic malaria. So the mortality rate for all malaria in the United Kingdom is 2.5% if you weren't born in an endemic country, and less than 0.5% if you were born. So of those 184 deaths, although 70% of cases nationally are in black Africans originally from endemic settings, most of the deaths are from white travellers who aren't from endemic settings, or black travellers who never grew up in an endemic setting. Fine. So you should make sure that you are seen in London if you have malaria. This is a graph that plots how likely you are to die versus how many cases of malaria are seen in the place where you are seen. And there is a very, very strong association. So Chris Whitty calls this the driving up the M1 graph. Basically, as you drive away from London, your chance of dying from severe malaria in the United Kingdom goes up very, very high. And that's going to be multifactorial: lack of recognition, delay in diagnosis, unavailability of specialist input. But so we're all very lucky. The case fatality rate in London is even lower than for the rest of the country by quite a long way. So I'm going to talk a little bit about the HTD experience. So this is nearly all pre-artesunate data, and pre-artesunate, many of the very ill patients with malaria in the United Kingdom were transferred to HTD for kind of specialist input, consideration of exchange transfusion, etc., etc. And the hospital saw about 167 between 1994 and 2014, so that's about 10 a year, and we could get hold of the notes for 124. And so I'm just going to show you some of the data about kind of what that group of people look like who come to intensive care with malaria. So slightly more men than women. They were 46. Oh, yeah. So they're kind of middle-aged-ish, not in that very, very high-risk group, which is more than 65, but not in the low-risk group, which is the people in this room. And converse to national reported figures, about 50% of them were white, and that would be in keeping with the kind of nationally reported data. And more than half were raised outside of an endemic area. Obviously, that means quite a few people were born in an endemic area. So although their individual risk is lower, because they make up such a large proportion of the total case burden, they still make up a large proportion of the cases that end up on intensive care. And somewhat depressingly, 90% of people had taken no or inadequate chemoprophylaxis. One person out of 124 had taken adequate. You can see that doesn't add up to 100 because there are X number of people where the data was not available, which almost certainly means they didn't take it. So overwhelmingly, these people do not take chemoprophylaxis. And there is reasonable data from the UK to suggest that even if you get malaria, if you have taken chemoprophylaxis, your risk of getting severe disease or ending up on intensive care is reduced. So even if you get breakthrough malaria, despite your Malarone or your doxycycline, you're less likely to get sick. And that kind of makes sense. And what kind of things did people have when they walked in the door? So depends which guideline you read and which number you like about how high your parasite count has to be for it to be hyperparasitemia. 2, 4, 5 and 10, depending on UK or WHO 2007 or 2010 guidelines. We use these two slightly arbitrary cutoffs. So I think the key point here is that many people who ended up on intensive care did not have profound hyperparasitemia. So 1 in 5 people who ended up on ITU with malaria had a parasite count of less than 2%, and 4 out of 10 people had a parasite count of less than 5%. So these are numbers which I think, 5% we kind of know is high, but it's not like that 10 or 12% that people really worry about. And then, unsurprisingly for sick people, about a third of people are acidotic. The WHO has this incredibly high number to qualify for acute kidney injury. So that would be AKI stage 3 on the Akin criteria. So about a quarter of people have profound renal impairment. About 15% of people have impaired GCS, which is the kind of working diagnosis for cerebral malaria. There is a strict criteria, which is seizures followed by a decrease in GCS that persists for at least 2 hours. But in reality, most people just say, if your GCS drops, then you've got cerebral malaria. A small percentage of people are shocked, and coagulopathy is quite uncommon. You can see that seizures are relatively uncommon compared to impaired GCS. And on the door, very few people have ARDS. So just for comparison, this is one of those horrid graphs that you never want to look at. These are all of, or many of the published non-endemic setting intensive care studies. So the one that Phil alluded to is this one here, Brunel 2010, that's the largest study. It's about 410 patients, 42 hospitals. So each hospital only saw a very small number of people. And it's a bit cheeky because they published a very similar data set in 2003, which includes quite a few of the same people. Anyway, and then there are studies from Switzerland, Germany, England, South Africa, Singapore, Portugal. And the key point is you'll see that in all of these studies, as in our UK data, hyperparasitemia is not consistently found in people that end up in intensive care. Acute kidney injury is pretty common. Somewhere between a third and half of people get AKI. Impaired consciousness, slightly variably defined, is found in about 1 in 5 to 1 in 3. ARDS varies a lot, and probably the main determinant of the variance in that is whether or not they recorded it on the day that someone came into hospital, or whether or not you ever developed ARDS during your stay. And I'll come back to that, but that would make a big difference to how much ARDS you recorded in association with your malaria. And then mortality varies wildly across these studies from optimistically 0%, these are quite small studies, to, in the worst case, kind of 25 or 29%. So obviously if you end up on intensive care with malaria, you're quite sick. So coming back to why the timing matters, these are probably the 3 major severe manifestations that really drive admissions to ITU with malaria in the UK. Cerebral malaria, because you need to be intubated. AKI, because you need dialysis. ARDS, because you need to be intubated. And you can see that overwhelmingly, of the people that developed cerebral malaria or AKI, they develop it on day 1 or day 2 of their admission. So you tend to present with a low GCS and a very high creatinine. And there isn't that much of all the ARDS that occurs on day 1, and that basically follows through on day 2, day 3, day 4, so it lags behind the rest of the complications. And that's mirrored by the parasitemia that you tend to have at the time that you develop your complications. So this is a confusing log scale on the left, but it shows the kind of mean log score parasite count that you had. So you can see that the parasitemia at the time that you develop cerebral malaria or acute kidney injury is much higher than ARDS. Remember, this is a log scale, so that's a 10-fold change, and that's a 100-fold change. So typically what happens is these people have a parasite count of 5 or 10% and cerebral malaria, and you give them your quinine or your artesunate or whatever you give them, and the parasite count comes down, and everyone's very relieved because they wake up, and now the parasite count's 0.1 or 0.01%, and then on day 5, all of a sudden they have to be intubated again because they've developed ARDS. So that's just kind of a note of caution to say, just because the parasite count's coming down, if they've been very sick, they're still at risk of this as a kind of delayed thing. And in keeping with that, you can see that the organ support requirements in these different studies are probably as you would expect. Nearly all of them used quinine to treat their patients. Apart from our data, we had some artesunate, and renal replacement therapy is needed variably up to about 40%. Ventilation is needed more frequently because it's needed both for ARDS and cerebral malaria. Lots of people get inotropes. Some people like exchange transfusion. Some people don't like exchange transfusion. And you stay on ITU for something like 4 to 8 days, probably. I'm not going to talk about artesunate, but I think everyone probably knows this is the drug of choice now for severe malaria, as shown in Secremat in adults with severe malaria in Southeast Asia and Acmat in children with severe malaria in Africa. There is a lot of interest now in this thing called post-artesunate delayed hemolysis, PADH, where people appear to get a profound hemolytic anemia occurring about 10 to 14 days after treatment with artesunate. And there was a really nice paper presented at ASTMH about this, showing that this is basically, the title of the paper says something like, post-artesunate delayed hemolysis is a predictable effect of the life-saving effect of the drug. So the way artesunate works is you get little pits on the surface of the red cells, and as the cells go through the spleen, it cleaves out those pits and removes the parasite, but those pitted cells then have a reduced lifespan. So if you have a very, very high burden of disease and the drug works very, very quickly, you get huge numbers of these pitted cells developing, which then only last about 10 days. So about 10 days later, you get profound delayed hemolysis. But it is a predictable effect of this drug. And it occurs mostly in people who've got the highest initial parasitemia. Exchange transfusion, there's no high-quality evidence for exchange transfusion. There's some observational data that says it works. There's some observational data that says it doesn't work. All of the observational data is basically junk. HCD haven't done an exchange transfusion since they introduced artesunate into clinical practice. So they haven't exchanged anyone in the last, I'm going to say 7 years now. I think that's about right. These are tried and failed. So these are clever things that the intensive care doctor will suggest would be a really good idea to give to your patient. Maybe they'll have some steroids because there's probably some swelling in the brain in cerebral malaria. That doesn't work. It kills you. Heparin's been tried. It doesn't work. Anti-TNF agent's been tried. Doesn't work. Petoxyfluorine, aspirin doesn't work. Mannitol's been tried in a pretty good study where people had confirmed cerebral edema on imaging. So this wasn't just any old cerebral malaria. These are people that we knew objectively had edematous brains, and they randomized them to mannitol or not, and the mannitol group died more. Iron chelation's been tried. Phenobarbital's been tried. So if you put EEG monitors on people who have cerebral malaria, they all have subclinical seizure activity, even if they are not overtly fitting. So people said, well, these people have all got subclinical seizure activity, we should give them antiepileptics. So that's been tried in several studies and it kills you. Now, phenobarbital is not a very nice drug, so maybe this isn't that there's no evidence for any antiepileptic drug, but phenobarbital definitely doesn't work. Levamisole was tried last year, doesn't work. N-acetylcysteine doesn't work. And if you're at somewhere like UCH or Tommy's, people like putting very expensive pieces of equipment into you to measure your extravascular lung water, and they'll tell you that this number means something. And Nick White and colleagues, who are probably the experts on this, did a really beautiful study in Southeast Asia where they put picos into people, and they basically said, can you use a PICO or invasive hemodynamic monitoring to guide fluid resuscitation, which is what people would do for other conditions? And the answer is no, you can't do that. And that's probably because the mechanism of lactic acidosis and impaired circulation is to do with sequestration and not really to do with classical circulatory collapse. Can you predict how people will do? There are several scores that people have tried for predicting outcomes. They're all from endemic settings. This is probably the best one, which is called the CAM score, the Cerebral Malaria Acidosis score. And you calculate it using the GCS and any one of these three markers of your acid-base status. So GCS, you score 0, 1 or 2, and then depending on what's available in your hospital, basically, you pick one of these, respiratory rate being presumed to be a proxy for your acid-base status. And in several cohorts, that's been shown to be quite a good predictor. So if you've got a CAM score of 0, you're not going to die, and if you've got a CAM score of 4, you are going to die. There's no data on this really in non-endemic settings. It was true in the HTD cohort of patients that if you had a CAM score of 0, you didn't die. So it's got reasonable negative predictive value, not great positive predictive value. And just to finish, to say what is it that kills people who have malaria on the intensive care? So these are the 5 deaths from the 125 ITU patients in the UK. Just to show, as expected from that demographics, they were slightly more white than they were black Africans. And there are a few people who are in the 1 very old person and a 2, we'll call those middle-aged people, and 2 younger people. And you'll see, you'll see they were all quite sick. I think the key point here really is like what they died of. This young girl, she probably died of malaria. She died on day 3. She still had lots of parasites. Gentleman number 2 died of being on intensive care. Gentleman number 3 died of being on intensive care. Gentleman number 4 died of being on intensive care. And gentleman number 5 died of being on intensive care. So overwhelmingly, actually, these days, in a non-endemic setting, if you get admitted to an intensive care, you don't normally die of your malaria. You die of line sepsis or ventilator-associated pneumonia or complications of being an old person stuffed full of inotropes.
Number 4 died of being given
quinine
amlodrone on top of flecainide on top of quinine with 3 class 1 drugs. I think we killed that one.
Cracking. I think that's my last slide. So in summary, it's probably still the most common serious imported infection. The overall mortality in the UK is very low. Older age is the overwhelming risk factor, particularly being more than 65. Most deaths on ICU are not malaria. So get the patient off intensive care as quickly as you can, bearing in mind that risk of ARDS at day 5 or day 6. Artesunate is the drug of choice. It's all supportive care, no matter what your intensive care colleagues would like to throw at the patient. None of them work. There's no role for adjuvant therapy at this time. The end.
Excellent. Great.